Oh my god, where is your face? Holy shit. Hi friends! Welcome back to Cygoth. My name is Courtney, and here is part 2 of the Strangest Medical Conditions Iceberg. If you haven't watched part 1, I will link it in a card here. Or maybe it's down here, maybe even up here. Here? I don't know, just fucking click it when it pops up, alright? If you haven't already, please hit like and subscribe to see some more medical content. Enough ticking around, let's get into it. Now this one is a fair bit bigger than part 1, so we're gonna be here a while. Grab some coffee, grab some snacks, energy drinks, whatever helps you get through it, because we're gonna go deeper. Deeper than the foxtail man and your mum. Progeria, short for Hutchinson-Gilford progeria syndrome, was first described by 2 doctors, Jonathan Hutchinson in 1886 and Hastings Gilford in 1897. Progeria belongs to a group of disorders known as laminopathies. These include muscular dystrophies, peripheral neuropathies, lipodystrophy syndromes, and accelerating aging disorders. It's thought to be extremely rare, occurring only in 1 in 4 to 8 million children, with fewer than 3,000 living patients, as according to a 2022 paper. The mutation that causes progeria can be inherited either in an autosomal dominant pattern or de novo. It primarily affects bone, vascular smooth muscle, and skeletal muscle. The symptoms of progeria are listed here in this cute infographic. At birth, children with progeria appear to be fine, physically and developmentally. It's only after 6 months of life that the physical symptoms start to become evident. It's most obvious in the skeletal and facial features: bulging eyes, lack of cheek fat, veiny scalp, abnormal teeth, among others. Cisneros et al. In their 2023 paper highlights step by step at each developmental stage what occurs, but that's a video in and of itself. The internal symptoms of cellular aging and blood vessel dysfunction, we'll talk about those in a bit. Life expectancy ranges from 6 to 20 years old, with most passing away between 13 and 16 from cardiovascular problems. Among those that survived into their teenage years with progeria, the most well known is the sweet Adalia Rose, who tragically died in 2022 at the age of 15. I flicked her hair Instagram and loved seeing how someone with such a debilitating disease lived her life to the fullest. Rest in peace, Adalia. How does a disease so bizarre come about? That genetic mutation I talked about is a mutation in a gene called LMNA, or lamin A, coding for a protein called, guess what, lamin A. This protein is important in the structure of the nuclear envelope, so the layer that separates the DNA from the rest of the cell. When LMNA is mutated in a specific way, instead of producing the normal lamin A protein, it produces its shit-stirring cousin progerin. Progerin acts as a dominant negative protein, which kind of means it's overpowered and evil. Like Tom Nook. It not only dicks up the nuclear envelope structure, but it also interferes with other processes that lead down the path to rapid cell senescence or aging. In their 2022 paper, Ursula Lamas et al. Coined the term progerin toxicity to describe the changes that occur when progerin levels increase. Now obviously people without progeria go through aging. It just happens much, much slower. Over time, our cells divide and divide and divide until they get exhausted and die. Mood. But the way in which this can be measured is the length of the telomeres. Telomeres are like protective hard hats that sit on the end of the chromosome tips. Every time the chromosomes unwind and reform, a little bit of the telomere is shaved away. Eventually, the telomeres get completely worn away and then the cell kind of gives up. Progerin is detected in healthy individuals, just at a much lower level, like 50-fold. But even this is enough to cause cell aging. So again, clearly, everybody goes through aging. But why does it go from 0 to 100 in kids with progeria? In a nutshell, it's because progerin and reactive oxidative stress lead to persistent DNA damage and faster telomere shortening. There are other abnormalities that scientists have picked up in people with progeria, such as having comparatively shorter telomeres and their mitochondria are misshapen and less motile. This in turn lowers their ability to produce energy as well as dealing with normal oxidative stress. The reason progeria has such young victims is because of the disease's impact on the cardiovascular system. High progerin levels in the endothelial cells, or the cells that line the inside of the blood vessels, causes inflammation, oxidative stress, DNA damage, and increased rate of aging. Many of these cardiovascular conditions come up because of the endothelial cells going bonkers. It starts off with progressively worsening vascular stiffness, followed by hypertension or high blood pressure, plaques in the blood vessel lining, angina, cardiomegaly or increased heart size, metabolic syndrome, and congestive heart failure. Premature progressive atherosclerosis leading to these cardiac problems is the main cause of death. In a nutshell, atherosclerosis is when the inside of the blood vessel gets lined up with crap, such as cholesterol, low-density lipoproteins, and dead cells trying to eat all of it up, which makes it hard for blood to flow through properly, leading to cardiac arrest or strokes. Well, that fucking sucks. I mean, you get a random mutation before you're even born and you end up with progeria. What can be done about it? Spoiler alert, not much. But various new treatments targeting progeria at the cellular level have become more and more successful. And these treatments have been shown to not only improve the symptoms, but also extend the lifespan of people with progeria. This is a step-by-step overview of how treatments target different steps of the disease process, from correcting the DNA sequence to prevent progerin from forming, to restoring proper protein levels. Resveratrol, a natural antioxidant found in blueberries and peanuts, has been found to ease the symptoms of progeria and in some experimental papers has improved the lifespan of mice. Rapamycin, an antibiotic, has a special immunosuppressive ability. It delays the beginning of cellular aging and normalizes the weird shape of the nuclear envelope. Pretty much what it does is recruit special enzymes to come and shred up the progerin, making room for normal laminae. Lonafarnib, an anti-cancer drug, prevents the accumulation of progerin in the cell by means of a chemical called FTI. In 2022, Lamas et al. Reported that FTI therapy can increase one's lifespan by 1.6 years. It can take a minimum of 2 years to see improvements in bone structure, weight gain, and vascular stretchiness. There is, however, one concerning side effect. It can alter the nucleus of these cells, making it more difficult for them to divide. Pravastatin, a fat-lowering drug, decreases DNA damage. It can be paired with lonafarnib to target the defective nucleus. It can also be paired with zoledronate, which is a bone-supporting drug. Finally, I want to talk about a study by Majiri et al. In 2021. In this study, they wanted to see if lengthening the telomeres would reverse the aging effect in the endothelial cells, the ones that lie underneath the lining of the blood vessel, which are also the ones connected with all of these cardiovascular problems. They utilized an enzyme called human telomerase reverse transcriptase, which guards the telomeres. They found that HTERT treatment extends telomere length, restores replicative capacity, and improves function in endothelial cells with progeria. Vascular rejuvenation using HTERT is a promising approach for progeria and other age-related diseases. Thanks to the work of the Progeria Research Foundation, research continues to improving the treatment of progeria to one day give every child with progeria a long and happy life. Hyperthymesia, also known as highly superior autobiographical memory, is basically the brain being able to store the most mundane information for decades. It is incredibly rare. As of 2024, only 62 people worldwide have been identified as having HSAM. Now, it's not to be confused with other types of memory, such as hypermnesia or superior memory. It's different in that it's a continuous autonomic memory, specifically of their own lives. I guess let's think of HSAM as a combination of, I remember this too well. My brain won't let me forget this. And I only just forgot what colour top I was wearing on July 19th, 1997. Fuck, I'd do anything to have that kind of memory for uni. There are two defining features to it, the latter being completely unique to HSAM. The first is a preoccupation with the past. You can't think of the future or the present. Your brain is stuck in the past. The second is an amazing ability to recall it. You could ask them, again, what colour top they were wearing 20 years ago on this time at this date. They'll be able to tell you. In some of the papers I looked at, comparisons were being drawn to other conditions such as OCD, PTSD, and autism. In a 2025 paper, Wani et al. Discussed the similarities specifically between HSAM and autism. While one is a condition on the autism spectrum disorder and the other generally isn't considered on the ASD, they do have some striking similarities in terms of memory retention. So let's have a look at this table. Both have an interest in dates, although it's more common in autistic savants. They both struggle to recall random facts, though it is variable in autism. The memory of painful events can be intense for both conditions, though in autism, it's shown to depend on the level or severity of the autism. Finally, trying to forget memories are difficult in both HSAM and autism. In a paper from earlier this year, Ferrarello and Baglieri highlight the similarities between HSAM and PTSD. Not only do both conditions feature invasive thoughts of past events, people with these conditions describe themselves as being stuck in the past and isolated, and the flow of negative memories is just really hard to let go of. On the neurological level, HSAM and PTSD memories work pretty much the same. That is, they go through the same process. In 2018, Santangelo et al. Conducted an experiment observing people with HSAM, noting that they tended to express obsessive and/or compulsive symptoms. In the experimental papers I read, they used PET scans and fMRI to see if there were any physical or functional differences that occur in people with HSAM. Wani et al. Found differences in the hippocampus, prefrontal cortex, and other areas surrounding them that support their functions. Santangelo also noticed differences in the hippocampus and prefrontal cortex, but also noted twice as many brain regions were activated during memory recall as opposed to people that don't have HSAM. Ferrarello didn't find much, but they did find hyperactivity and extra connectivity between the hippocampus and the amygdala. Finally, Laporte noticed differences in the grey and white matter in the brain, which we talked about in part 1. But as a refresher, the grey matter is the outer layer of the brain. The white matter is the inner layer of the brain. Maybe I shouldn't have said that. Maybe you would have gone and watched part 1. So anyway, what they notice is increased amounts of both grey and white matter. More grey matter correlated with better memory. More white matter makes it easier for the brain to send messages to each of these different parts. Let's talk about some case studies. In 2006, Parker et al. Interviewed a hypernesiac named AJ. They were quoted as saying, "My memory has ruled my life. It's like my sixth sense. It's a gift I wouldn't want to lose." How poetic. Now, what's interesting to me is that in the majority of the literature, people interviewed with HSAM describe it as a negative thing. You know, it's invasive, they can't stop it, they wish they could. But clearly, AJ thinks differently. I wish I could share the full document with you, but unfortunately, it's locked behind a paywall. And one day I'm going to make a video about how much I fucking hate these paywalls. There's an interesting perspective that was shared by Court et al. In their 2025 paper, describing HSAM as a form of time travel. They featured a case study of an unnamed hypomnesiac, describing an incident where at 8 years old, her friends called her a liar because she could relive her memories and check for details. She describes the time when she finally told her parents about her unique ability, only to be told that other members in the family experience forms of synesthesia, which we'll talk about later in the Iceberg. Finally, in 2008, Jill Price, another hypomnesiac, published her autobiography about her life with this unique condition. You can check her Wikipedia page and potentially find that autobiography. The question that often comes up in these case studies: should HSAM be considered a disorder? Ferrarello and Baglieri propose that it should be considered a phenomenon instead of a disorder, based on a theory proposed by Herschel, which is well beyond the scope of this video. I'm sorry. In short, they go on to say that being labelled as a phenomenon is more descriptive of the lives and experiences of people with HSAM as opposed to a disorder. I mean, certainly, if HSAM is considered a phenomenon instead of a disorder, it would be much less stigmatizing. No one wants to be labelled with a disorder. It's not fun. I know that the consensus, based on the literature that I've read, is that people with HSAM describe it as a negative thing. You know, these pervasive thoughts that you can't move past. So I get why some people would argue that it is a disorder. Fact is, there's just not enough evidence out there. There's 62 people in the world that have been categorized as having HSAM. Strap in, this is going to be a big one. Human African Trypanosomiasis, otherwise known as sleeping sickness, affects up to 70,000 people worldwide. It was reported in 2017 that rates have reduced by 85%. It's rare to see in tourists, but it's very common in immigrants and refugees. HAT is caused by two members of the parasitic family Trypanosoma brucei. TB gambiense, or GHAT, is endemic in Western and Central Africa. Its cousin, TB rhodesiense, or RHAT, is prevalent in Eastern and Southern Africa. And yes, this is important, because everything from presentation to treatment is dictated based on which of these two little buggers is causing the disease. GHAT is a chronic condition spanning years, whereas RHAT develops much quicker over weeks and months. The life cycle of these baddies are as follows. A tsetse fly, unknowingly harboring these stringy johnnies, takes a blood meal from a human. Num num. The trypanosome that lingered in the fly's saliva slides its way into the human's blood. When the trypanosoma is comfy, he Sailor Moon transforms into Slender Man and begins to multiply. Eventually, he shrinks down into a stumpy boy. He's short and fed up with multiplying. Next, another tsetse comes along, chomps, and accidentally stocks up the stumpy boy. The stumpy boy hangs out in the gut of the fly until he's hit his midlife crisis and decides to hang out in the salivary glands. Now he's dyed his white hair black and started wearing tacky gold jewelry. He's in the air/spit port waiting to catch a flight to Mammal Tissue City. There's a couple of elements that are important in the transmission of the trypanosoma. GHAT spreads between people, whereas RHAT spreads between mammals and people. Actions in the environment, such as washing clothes, hunting and fishing, and the prevalence of the dreaded tsetse fly. In both versions of HAT, there are two stages. The first is the hemolymphatic stage, and the second is the meningoencephalitic stage. If left untreated, it will go on to organ failure and death. Like I mentioned before, GHAT is a chronic condition, usually spanning about 3 years from onset to death. In contrast, RHAT usually lasts about 6 months from onset to death. And in both of these conditions, the time spent in each phase is equally divided. It all starts with a large sore developing at the bite site. After this, symptoms can arise from 1 to 3 weeks after, such as chronic intermittent fevers, usually lasting a week with breaks in between, headaches, itchiness, swollen lymph nodes, and hepatosplenomegaly, so enlargement of the spleen and the liver. The second stage usually develops at the 500-day mark for GHAT or 60-day mark for RHAT. The characteristic sleep disturbances that give the name sleeping sickness start, along with tremors, weird jerky movement, heart rhythm changes, and aggressive psychotic behavior. Just like me after a bottle of Prosecco. So how do we diagnose them? The methods between G-HAT and R-HAT vary. The first thing is determining how long ago the bite was and how quickly the symptoms started. Diagnosing R-HAT is as simple as looking at a blood slide because the fuckers are everywhere, but not so much in G-HAT. Additionally, you can't tell which one is which under the microscope. In G-HAT, there's a few extra steps. The first being a card agglutination test for trypanosoma. It works sort of like a COVID test, but instead of swabbing your nose or your throat, they take the patient's blood. So the blood is mixed with a chemical and placed onto the card. If the parasite is in there, your body is already producing antibodies to fight against it, and they sort of cling onto the surface like how I cling on to the last straw of my sanity. So if we mix the blood with this other chemical and it starts to clump or agglutinate, we know that the parasite is in there. And then we do more diagnostic tests. From there, either more blood or lymph fluid is taken from the patient and analysed through a bunch of machines that I don't have time to talk about. But it is the definitive diagnostic tool for determining which parasite is causing the disease. Now, to determine which stage the disease is at, the doctors will take cerebrospinal fluid, or CSF, for analysis. So CSF is a fluid that runs through your spinal column and around your brain. It sort of acts as an extra cushioning for your spinal cord and your brain. So looking at the CSF, if it's only stage 1, then you're only going to see 5 or so white blood cells per volume of spinal fluid, so not much. In stage 2, there's bound to be lots of white blood cells and any amount of parasites. So even if that's just 1, we know that the parasites have moved in onto the brain tissue and meninges, the meningoencephalitic stage. For stage 1 G-HAT, the drugs of choice are penamidine and eflornithine. Eflornithine combined with nifurtimox boasts a 98% cure rate with only a few side effects, which would be great unless you're allergic to it or you're too young to take it. In stage 1 R-HAT, there is only one drug of choice, which is Suramin. If it's second stage in either type of HAT, say your prayers, cause you're stuck with milosapol, a nasty drug with nasty side effects, including blindness. And there's a 5 to 18% chance that you'll end up with brain damage. I don't know about you, but I don't like those odds. There is a higher risk of brain damage in R-HAT, but I think that's because there's a whole lot of them floating around as opposed to G-HAT. Earlier this year, Barrett et al. Talked about the heaven-sent alternative, fexinidil. It was approved by the FDA in 2018, and it's suitable for treatment in both G and R-HAT. The best thing about it is that it is an oral tablet that can be taken at home, which is more preferable than several months in a hospital bed. Of course, every drug has their side effects. I don't know about you, but I'd rather have a bit of a dicky tummy than risking brain damage. There's not much left up in this peanut. I can't risk losing any more. Unfortunately, there is no preventative vaccine. There have been attempts that worked really good in the lab, but failed out in the field. I have my thoughts on why that could be, but I don't really know too much about parasitology. Maybe it's a case of the lab-produced antibodies not matching up with the cell surface antigens of wild trypanosoma. Oh, too much? Really, all you can do is avoid the dreaded tsetse fly. There's numerous ways that you can avoid them, such as avoiding wearing dark colours. Wearing thick clothes so that the tsetse can't bite through into the skin. And you can test your luck with insect repellents, but studies have shown that it's not really that effective. I know this topic has been a 2-for-1 special, and I don't blame you if it was hard to follow. I made up this table summarising the differences between G-HAT and R-HAT. Hopefully this makes it a little bit easier to digest. Jamie Ward describes synesthesia as a remarkable way of perceiving the world. I wish I had the kind to make this literature easy to read. This one was a bit harder to find recent studies on, seeing as I clicked on search since 2001 and it came up with a lot of robot stuff. Go figure. Instead, I have had to rely on studies that were published a little bit earlier. So, unfortunately, I don't have the latest in the field, but comment below if there's anything that I've missed. Additionally, there is a lot of complicated language that I tried desperately to translate. I don't think I did it very well. Synesthesia was first recorded over 200 years ago, and it affects 1 in 2,000 to 25,000 people. What? Now, you don't have to be the smartest person in the world to ask yourself, what the fuck? There were a lot of different studies that I read, and all of them had different numbers. So what I did was take the smallest number that I found in a study and the largest number that I found in a different study. The most commonly recorded form of synesthesia is grapheme to colour. This means that people see numbers and letters in different colours. Some of the more interesting examples I found in the literature were the name Philip tasting of sour oranges. Yum yum. The letter A being a striking red, and the strangely esoteric example of a C sharp on a violin looking like a brown fuzzy line extending from left to right. Brown note. I think I've heard of something similar.
The brown noise. Can you hear me? Found the brown noise. Here, look. Okay. Ready? Woo.
I'm 32 in 6 weeks' time, but South Park will have my heart forever. Ward goes on to list some influential figures that have synesthesia, such as Ludwig Wittgenstein, who saw the letter E as yellow. That's super cute. Olivia Messiaen, who saw musical keys as colours. And Geoffrey Rush, who sees coloured numbers and days. If you've seen Quill, fantastic film, you'll notice that you see all of his writing in brown. That's not a synesthetic occurrence, that's just him penning it with its own shape. There are other types of synesthesia that have been recorded in literature, such as audiovisual, word taste, spatial sequence, such as the months of the year going in a circle, auditory tactile, and there were plenty more. I just picked the most common ones. This phenomenon is different to illusions or hallucinations. Synesthesia requires an inducer or trigger, and it needs to be concurrent or involuntary. By definition, illusions are just misperceptions, and hallucinations don't require a trigger to experience the concurrent events. Edward Hubbard is a particularly prominent name in this field, and I looked at a couple of his articles. He adds that the experience must be unique, lifelong, so not once off or a short period of time, and it needs to be automatic, without conscious effort. You could look at the letter A in black text and imagine it being the colour red. A synesthetic can't do that. It's a case of perception versus mental imagery. Synesthesia could be developmental or acquired. Someone could be born with this ability, even though there's no correlation between genetics and heritability. Even if two relatives have synesthesia, they often won't experience the same type. The most common form of acquired synesthesia is amputation and phantom limb pain. Even though synesthetics experience the world differently to others, there are several papers that list common ground, independent of environment, on which they agree. High-pitched sounds are brighter and smaller in space. Common letters are red and yellow, whereas uncommon letters are purple and brown. Single digits progress from light to dark as the number increases. There's not a lot of consensus as to which areas of the brain are implicated in synesthesia. Hell, they can't even figure out what side of the brain is implicated. But I'll put down the things that were most commonly mentioned in the literature. There are a few structural changes that have been noticed in synesthetics. Synesthetics tend to have more white and grey brain matter, which increases the speed of signal transmission. Compared to non-synesthetics, synesthetics have structural differences in their parietal and frontal lobes, as well as the retrosplenial region. Activity in the brain between different regions has also been found. The colour-sensitive fusiform cortex may explain why grapheme to colour synesthesia is the most common type. Hang on, bear with me. The posterior inferior temporal... This junction is related to visual processing and spatial awareness. Hyperactivity in the parietal lobe might lead to an unrestricted joining of multiple sensory areas. Now this is the stuff I understand. The increased amount of white matter makes it faster than normal to send all of these signals to the major multisensory processing regions, and specifically the ones related to colour, which makes sense that most of these synesthesias that have been recorded are colour related. I think Ward was right. It really is a remarkable way to experience the world. I'm sure you remember in the first part that I prefer to talk about human disease. Well, this time I can't get out of it. Unfortunately for me, Gasterophilus really infects humans. When it does, it's called cutaneous migratory myiasis, which we'll talk about at the very end of the video. Stay tuned, that one's gonna be nuts. Oh, he's missing his eye. So if you're into horses, this might be a little confronting. I've already comforted 7-year-old horse Courtney. Gasterophilus, also known as the horse botfly, tends to infect horses, zebras, and donkeys. There's 1,000,001 different species that affect different areas of the horse. The most common ones are Gasterophilus intestinalis, most widely distributed. It lays tiny yellow eggs on the forelegs, undercarriage and mane. Gasterophilus hemorrhoidalis. This one actually lays its eggs in the underside of the horse's chin, but likes to stick to the rectal lining. And Gasterophilus nasalis. This one at least lives up to its name. This nosebot lays tiny black eggs on the muzzle. The botfly lays its eggs on the horse. That's it. It doesn't even have a mouth. It lives to destroy. The horse ingests the eggs, for example, chewing on the forelegs. The eggs then travel to, and incubate in, the gut of the horse for roughly 8 months. They're in it for the long run. It passes through the pony poo chute and chills out for up to 5 days before adult botflies emerge. There are usually no signs of an infestation, however ulceration can occur, which has been a common observation in the literature I read. They still cause damage to various areas of the horse, most notably the stomach lining. Okay, so you've found some of the little bastards on your horse. What do? The main drug to use is ivermectin, an anti-helminthic drug that we all know about for the wrong reasons. Ivermectin targets the oral and the gut-dwelling larvae. An Equimed article from earlier this year also recommends ivermectin over other anti-helminthic drugs. They also recommend removing any of the fly eggs that you see with an abrasive sponge or a stone. I'm sorry, there wasn't really much literature on the topic, and what there was very limited. We're just gonna have to move on now. How the fuck do I pronounce this?
Vitiligo.
Vitiligo. Huh. If you remember from part 1, I compared vitiligo to piebaldism. Well, it's time to revisit it. Vitiligo affects 2% of the world's population. While there is a genetic element, developing vitiligo is much more complex than simply getting the gene. In fact, according to Marchiaro et al. In 2022, there's only an 83% genetic element in there. So what's the rest of it? Vitiligo is an autoimmune disease which leads patches of skin to completely lose their pigment. It starts by the immune cells attacking the melanocyte or skin pigment cell. There's something kinda sus about the cells that are meant to regulate what I call Dicky cell destruction. They took a bribe and turned the other way, like a crooked cop. The white patches associated with vitiligo are mostly physical changes to the upper levels of the skin, which supports the idea that environmental factors contribute to vitiligo, as well as inflammatory chemicals getting into that tissue. Fun fact! There are 2 different types of vitiligo, as described by Gandhi et al. In 2022. There's segmental vitiligo, which is characterized by localized areas of depigmentation, but only on one side of the body, which includes the hair follicles, and has a rapid onset. In non-segmental vitiligo, the patches are symmetrical and can appear on any spot on the body. It has a more progressive development, and the involvement of hair follicles comes later in life. The distinction is important because it dictates the prognosis and treatment options. But how is it diagnosed when it looks so similar to piebald's? There are different patterns associated with vitiligo, most commonly presenting with white patches on the mouth, fingertips, and the genitals. You're just gonna have to take my word for that one. And because this is an autoimmune disease, there is a chance of developing other autoimmune diseases. There are a few different ways to treat vitiligo. Medication aiming at the autoimmune aspect, so immunosuppressants. Others treat the white patch aspect, using UV light waves to stimulate the pigment cells. However, using these methods, there is a risk of developing cancer. So it turns out this term is rarely used in literature, favouring the phrase body integrity identity disorder, or BIID. People with BIID, the self-proclaimed wannabes, have a strong feeling of being born in the wrong body. That is to say, being able-bodied. They describe a sense of identity with disabled people, and conversely, wanting to be disabled, especially with amputation. But it's not just about amputation, that's just the most common one. There's a lot of wannabes of different types wanting to be disabled in some way. You can find a lot of them on TikTok. I did find an absolutely brilliant study talking to people that have successfully gone from wannabes to gonabes. It was such a brilliant read. We'll talk about that at the end. In their 2015 experimental paper, Obernolte et al. Discussed the psychological origins of 36 people with BIID. Overall, there were no significant differences in typical childhood experiences compared to people without BIID, and this did include for participants with bad childhoods. What they did find, however, is that people with BIID were far more likely to have experience with certain handicaps and disabilities in their childhood, especially from amputees and people with palsy. In other words, the only significant factor that shifted these perceptions was being exposed to certain conditions. And before you ask, I've looked at various papers, and there are only a tiny subset of people with BIID that have a sexual connotation with it, so it's not common. Across the papers I read, there was a bit of discourse as to whether this should be considered a mental disorder in the DSM-5. And in his 2025 paper, Stambersky makes some good points. He argues that it should be compared to schizophrenia, in which they are a danger to themselves if not treated. An interesting article that I found actually looked at people with BIID and treatment with antidepressants and therapy. And they found that there was little to no difference in containing the impulses they had. In some people, the compulsion was dulled, but it wasn't eliminated entirely. And really, if you have a problem like this, where else do you go if medication and therapy doesn't work? Stambersky references a paper by Chakraborty published in 2021 that documents that people with BIID have injured themselves so severely that surgeons have no option but to amputate. Another study mentions that some people with BIID do not survive their attempts. My thought is, I know you're not here for my opinions, but my thought is, how far should we let bodily autonomy go? I am all for bodily autonomy, my body, my choice. But in this instance, it is your choice to go through something like this, but you're not the only one that's impacted. People have to start taking care of you. And we are going to go through a list of the most common amputations that have taken place, and some of them are going to need carers 24/7. So you're impacting somebody else's life because you wanted to fulfill a fantasy. And now for the paper I really wanted to talk about. In 2014, Knoll and Caston interviewed 21 people with BIID who successfully maimed themselves. Almost all of these amputations were leg amputations, one or both above or below the knee. Most of the participants went to a foreign country and spun a lie, which, no, I don't think I could trust any healthcare than Australian. The rest of them deliberately caused an accident which would force a surgeon's hand. They also measured their sort of emotional and mental state before and after surgery. Before surgery, on average, the effects of psychotherapy, medication, and relaxation sometimes increased the desire to maim themselves. Others they found no effect. And consistently amongst the cohort, after surgical procedures, was a massive increase in positive emotions. But were they satisfied after one surgery? I mean, is it kind of like Pringles where you pop one and you can't stop? Out of the 21, 17 said that they were fine and content with just one surgery. Only a few more desired more drastic measures. Reading the testimonies is quite interesting. Among all the testimonies that I've read through all these papers, you can come to two conclusions. One was that they were miserable and had incredibly strong compulsions. And the other is that they were ecstatic, that they finally became who they wanted to be. As one participant said, the advantages outweigh the disadvantages. The final sentence in this paper is quite powerful. As long as no other therapies exist, it may be better to help these people with an operation than to take the risk of deliberate accidents or operations in developing countries. And I think that really sums up what their point is. One last comment I want to make. Elective surgeries can be life-saving. We may not understand why somebody would want to get a BBL or a boob job, rhinoplasty, lip fillers, but does that really matter when the only person being affected by it is the patient themselves? In a positive way, no less. In this case, it's a bit of a grey area when it comes to who is being affected by a patient's desire to become an amputee. While I think there's virtually no reason for a surgeon to allow a voluntary amputation, I think it's unethical that people are being forced to such drastic measures, encountering the very real demonstrated risk of dying. But what do you think? Are you with Stambersky or are you with Nolan Caston? Let me know in the comments. Spina bifida is a neural tube defect that affects the base of the spine. It is the most common childhood disability and affects 220 babies globally. And there are three types of spina bifida. There is the occult type, where there's a gap in the spinal column, but the defect isn't visible on the outside, and therefore doesn't disable the child. There's the meningocele type. The gap is filled by a fluid-filled sac, but doesn't contain any spinal cord or nerves. And then there's the myelomeningocele. Part of the spinal cord and nerves form inside the fluid-filled sac. Because of this, there's other neurological abnormalities that can develop. This is the most common and also the most severe type. Early in embryonic development, approximately 18 days post-fertilization, the brain and spine are part of a flat disc. Over the next 2 weeks or so, the middle of the disc sinks inwards, and the part next to the sinking tissue close over it, forming the neural tube, the future central nervous system. All this, and the childbearer doesn't even know they're pregnant. If there's an incomplete seal along the neural tube, then the opening is prone to a defect forming in the gap. Diagnosis of spina bifida depends on blood tests and ultrasounding. Causes of spina bifida can be genetic or non-genetic, which includes the use of teratogenic medication, maternal diabetes, or the most important one, folate deficiency. Folate, also known as vitamin B9, is found in a variety of different foods. To prevent neural tube defects, it's recommended that the pregnant person should intake 400 micrograms per day. There's also supplements formulated specifically for the prevention of spina bifida. Research shows that areas of low economic status have higher rates of spina bifida. In my opinion, this could be linked to lack of access to healthcare, as well as fresh fruit and vegetables required to get that folate intake. There are various treatments that can be performed prenatally, or before the baby's born, or postnatally, after the baby's born. In prenatal treatments, a doctor can use fetoscopic surgery and/or a uterine incision to correct the defect on the baby's spine. If the baby has already been born, then corrective surgery will occur within 48 hours of birth. While this corrects the lump, there are other conditions associated with spina bifida, including hydrocephalus, which we'll talk about later in the iceberg, so stay tuned for that. A dysfunctional pelvic floor, high risk of obesity, and muscle weaknesses that lead to abnormal growth and other deformities. Hassan et al. Discuss new cell therapies in their 2022 paper. To summarize, they talked about using different types of stem cells on the neural tube defect area. Each method was shown not only to close the gap, but also restore neurological functionality. I'd go into more detail, but it's very technical and I wouldn't stop. Kuru is a fatal prion disease most found in the indigenous population of Papua New Guinea. In the native language, the word Kuru means tremble, one of the symptoms of this condition, which accompanies progressive neurological degeneration and death. How did this happen to them? By eating the brains of their relatives. Yum yum. Now that we've reached the halfway point of this video, if you like what you've seen, hit like and subscribe to see some more medical content and the rest of this iceberg, if and when I ever do. No. I will do it. It will just take me forever. It was first reported in 2 papers from 1957, documenting the symptoms they found in the indigenous community right after performing ritualistic cannibalism. When did eat the relatives become eat the rich? I'm down for it, but when did that happen? If you don't know what a prion is, it's basically just a misfolded protein. Think of protein folding as if you're folding a piece of paper. If you fold the protein like this, it's normal and it does its normal job. But if you fold it like this, it essentially becomes evil and leads to the development of spongiform encephalopathies. You may have also heard of mad cow disease. Both Kuru and mad cow disease are examples of transmissible spongiform encephalopathies. TSEs basically make the brain go spongy and replace the brain tissue with cysts. So yeah, moral of the story, don't eat brains. Although, when my stepdad was a kid, he grew up on a farm in the middle of nowhere. He would bring home friends from boarding school and they'd all have lunch. And the kids would be like, "Oh, Mrs. H, this tastes great. What is it?" And Gran would just turn around and be like, "Sheep's brains." They never ate there again. Unfortunately, the prion is allowed to run rampant because the immune system doesn't pick it up as a bad molecule. So wait. You're saying that the immune system can start to target the body's own organs for no reason at all, but it can't pick up on a misfolded protein? Make it make sense. Well, I will. The normal protein is identical to the misfolded protein. So it's kind of like getting a sentence, writing out a sentence. But instead of writing the sentence in one straight line from left to right in Western culture, you've written the sentence in 2 different lines. You've written half the sentence at the top and the rest of the sentence at the bottom. That's what misfolding proteins look like. So essentially, it's like wearing a hat and mustache and just slipping on by undetected. Now I know that you want to know more about the cannibalism thing. Its highest prevalence was between 1900 and 1950s, the mortality rate going as high as 3.5%, which is massive in a tiny community. One paper explained that women and children were more likely to contract Kuru because they were more likely to eat the brains, whereas men were more likely to eat the muscle. I always said I wish I had a brain, but I didn't mean on my dinner plate. It's important to distinguish Kuru from other forms of TSA. Kuru can take years or even decades to become symptomatic. What one would usually do is look at the patient's history, symptoms, and diagnostic tests to narrow down the cause. The most likely differential diagnoses would be mad cow disease or fatal familial insomnia. Both are caused by prions and present with similar symptoms. Speaking of, let's have a look at the 3 stages of Kuru disease and their symptoms. The first is the ambulatory stage. They're trembling, unsteady walking, and strangely enough, sporadic, uncontrollable, hysterical laughing. Okay. The sedentary stage, where they are unable to move on their own. They have jerky eye movements and uncontrolled muscle clenching, which would be so painful. And finally, there's the terminal stage. They become bedridden, incontinent, and unresponsive to external stimuli, even though they're fully conscious. Patients in this stage will usually die from pneumonia or infected bed sores from not being able to move themselves. There is no cure for Kuru. All one can do is make the patient comfortable. Pain meds, muscle relaxants, and rolling them in their beds frequently so they don't get those pressure bed sores. Death usually occurs within 1 to 2 years of the symptoms starting. Fun fact! Wow! According to Mahat and Asuncion, your genetics can either make you more susceptible or more resistant to developing Kuru. People with 2 copies of the mutated prion protein gene were more likely to have an earlier onset and a quicker death. People with only 1 mutated copy had a later onset and death was delayed. According to most of the articles I read, it's been about 20 years since Kuru has reared its ugly head. And yes, that pun was totally intended. Mad cow disease and other TSAs are still out there, so unless you're a carefree zombie, I'd avoid eating brains. This is a PSA channel now. You ever seen those My Strange Addiction clips where people are eating sand, mattresses, and rocks and shit? That's not them being quirky. They are suffering with a mental condition called pica. And I've never admitted this publicly before, but I have pica as well. No, I will not elaborate. It was actually researching this topic that I came to realize that some of my behaviors matched pica. And before we get started, I don't think I'd say I'm suffering from it. I don't think a lot of people would say they're suffering from it. But we are going to get down to some really bad complications of some types of pica. Defined by the DSM-5, pica is the persistent eating of nutritionally void non-food products for at least a month. It's applied to people that are at an inappropriate age to be putting weird shit in their mouth. So compare that to an infant or toddler that learns by putting random shit in their mouth. There's no cultural significance tied to it, such as the eating of white clay by African American women in Georgia. Finally, if this behavior comes in conjunction with another mental/developmental disorder or medical condition such as pregnancy, it needs to be severe enough to need extra medical attention. Based on some of the subtypes that I've seen, it is very likely that quite a fair few people with pica need medical attention. Here's a list of different phages that I found. Obviously, I looked past Wikipedia, but this was just a nice way of collating it all, and you can see that some are quite concerning. In his 2022 paper, Schnitzler outlines the most common types of pica in both adults and in children. In adults, it's usually geophagia, amylophagia, and pagophagia. In children, specifically with neurodevelopmental disorders and autism spectrum disorder, the most common ones are trichophagia, xylophagia, and coprophagia. While any form of pica can present medical concerns such as vitamin deficiency and iron deficiency anemia, others are objectively more dangerous. Ingestions of things like lead, wee, poo, vomit, wood, glass, metal, fibrous items like wool or hair can lead to development of things like lead poisoning, serious bacterial infections from biohazards, lacerations to the gastrointestinal tract, anywhere along it from glass and metal. The bundling of fibers in the stomach can block the passage between the end of the stomach and the duodenum, which is called the pyloric sphincter. This passageway is how food gets from our stomach to our small intestine, which can obviously prove very dangerous. Like, I've seen pictures of these hairballs that are actually shaped like the stomach, because it was that full and that compressed that it actually took on the shape of the stomach. It was wild, man. It was wild. And from what I've read, it's not uncommon for people with pica to die from this condition. The causes of pica are complex and multifactorial. Going off the literature I read, they identified two main causes, two root problems, so to speak. One is that they had diets that were vitamin deficient, as well as particular psychological stresses. Going back to Schnitzler, he offered the theory of Freudian oral fixation. That is, that unresolved issues in infancy led to the preoccupation of adults that needed something in their mouth all the time. And as an adult who feels most comfortable with something in their hands and their mouth, I feel quite attacked. I read a 2023 paper by Adhikari et al. Outlining clinical treatments for people with pica. Usually treatment begins in the ED room with strong stomach pain. People have either cut open some part of the gastrointestinal tract from eating something sharp, develop bacterial infections from eating biohazards, poisoning from things like eating lead or other hazardous substances, or even parasitological conditions. Once the danger's over, once the patient has been stabilized, the next thing is to look at their nutritional intake and balance their diet. If it keeps going, then there is also the option of behavioral intervention treatment. It's just like on My Strangest Addiction, except people there want to help, not humiliate. An interesting thing to note is that there were studies on whether antipsychotics or SSRIs could help with the problem. In some cases, they were just totally ineffective. In other cases, it made it worse. In 2015, Cole et al. Looked at the efficacy of different behavioral techniques for children with developmental disorders. Although there were only 11 participants, and usually we scoff and laugh at such a small cohort, as well as taking the results with a pinch of salt, they do go on to state that it is one of the largest cohorts of children with developmental disorders and pica. So the other studies they looked at didn't even have that many. They found that the most effective method was combining direct therapy to the children, as well as providing information to their caregivers. Incidences of pica were dropped by 90% in 10 children, 95% in 8 children, and 100% elimination in 3 children. If you, like myself, happen to show signs of pica, I would recommend getting some help before you end up in the ED. This unique skin condition makes up 10% of all chronic urticarias. It occurs when pressure is applied to the skin, either by rubbing against clothes or items, or even light scratching. It's also known as urticaria factitia, Latin for skin writing, because the pressure required is so small that you could write letters and the hives will take the shape of those letters. This one just happens to be my favorite example, not gonna lie. It's even seen in animals, like this horse image that I came across in one of the articles. Around 1.5 to 5% of patients have asymptomatic dermatographia, that is, that there's no itching. If there's itchiness as well as hives, it's considered symptomatic dermatographia, though this isn't very common. The mechanisms of this condition aren't well known, but I would hazard a guess that it has something to do with the activation of the inflammatory system and the involvement of white blood cells that initiate that process. Hey, editing Courtney here. I found an article that suggests that the release of histamine and heparin are part of it, which supports my guess about the blood cells. These are the principal white blood cells involved in allergic reactions: eosinophils, basophils, and mast cells. Each of the dots are granules from which they release chemicals, such as histamine and inflammatory cytokines, that cause the classic allergy symptoms we're familiar with. Okay, that's all I have to say. Back to the video. Diagnosis is fairly simple. The doctor will swipe a cotton swab along the forearm, and if a hive appears after a few minutes, then it's confirmed. Treatments for symptomatic patients, or the itchy ones, are pretty much limited to using antihistamines. The most commonly recommended ones are cetirizine and loratadine. These are non-drowsy, 24-hour coverage antihistamines. And as well as skin allergies, they also treat head allergies, so running eyes, running nose, that sort of thing. They also suggest using a 1,000 milligram vitamin C supplement every day. In a 2022 study by Ashkin et al., they examined the use of an artificial antibody called omalizumab. 26% of the participants in this study had symptomatic dermatographia. Amongst all the participants, overall, omalizumab had severely decreased the symptoms. Among the participants that had symptomatic dermatographia, 85% of them had a positive response to omalizumab, that is, that their symptoms reduced. Some even had complete elimination of their symptoms. Holy hell! I read some other papers looking at omalizumab, and they also found similar results. Hydrocephalus is a chronic intracranial condition in which certain areas of the brain called ventricles are abnormally large. This abnormal expansion is caused by too much cerebrospinal fluid flooding into them and putting pressure on the rest of the brain. In children, hydrocephalus occurs in 1 in 1,000 births. Now, CSF is a clear fluid found around our brain and spinal cord, which flows freely and evenly around them. It adds extra cushioning to our brains and spinal cords, along with bony structures such as our skull and vertebrae, and a trio of thin membranes, the meninges. There's the dura, arachnoid, and pia mater, to protect us from injury to those regions. It's kind of like a waterbed separating you from the bed, babe. place. There are two types of hydrocephalus, communicating and non-communicating. In communicating hydrocephalus, the fluid is blocked outside of the ventricle, and in non-communicating, the fluid is blocked inside the ventricle. This results in the inability to reabsorb the CSF through the drainage system and continue to flow. So there's childhood and adulthood hydrocephalus. Genetic causes arise before the baby is born. Remember how we talked about spina bifida? 85% of meningomyelocele kids develop hydrocephaly, or acquired forms, such as bleeding on the brain, infections, and even tumours, and can cause lifelong problems. There are also idiopathic forms, which have been linked to X chromosome mutations. Cases of hydrocephalus in the aged population is associated with normal intracranial pressure, and it also presents with unsteady walking, impaired cognition, and incontinence. There's a lot of different types of hydrocephalic conditions listed in the literature, but we'd be here all day. Diagnosis is based on the symptoms of raised intracranial pressure, head circumference, and brain scanning showing any signs of enlarged ventricles. They're also looking at any potential causes, such as tumours or bleeds. And using MRI, they can actually see the flow of the CSF through the system. The only treatment for hydrocephalus is surgery. In emergency cases, a lumbar drain can be inserted into the spine to drain the excess fluid that way, or they could use an extraventricular drain, or EVD. EVD requires a small hole to be drilled into the skull so that a small needle can be passed into the brain tissue to connect to the enlarged ventricle. Then a tube and a sac is attached to it so that the fluid can flow through into the sac, thereby draining the excess fluid. Once the pressure is normalized and the excess fluid is drained, a shunt is placed. Shunts are made of medical-grade silicone tubes that connect to two different areas of the brain, and they have a valve in the middle to control how much fluid is being drained. There are different shunts available depending on where the doctor wants the CSF drained to. Some can be placed from the brain to the pleural membrane, and others could be to the peritoneal cavity. It's not a perfect solution, with 50% of shunts failing before the age of 2. But it's either this or die. From then on, the patient will spend their lives attending regular brain scans and x-rays to make sure that the shunt is staying put. It is extremely important for patients to know when their shunt could be failing, because this is a life or death situation. I have a friend who their shunt started to fail on them at work, and she had no idea what was going on. I didn't press for details, because that could be the most traumatic thing that she's ever been through. But I didn't want to press her for details as to when she developed hydrocephalus, how many shunts she's had. It's not my business. She nearly died at work, and she had no idea what was going on, and I couldn't imagine, depending on a little piece of silicone in my body to keep me alive. So I'm just recording this because I figured, why talk about the importance of seeking medical treatment if I don't talk about how it can fail? So here I'm on the Hydrocephalus Association website, which, for a quick Google, I think that it's a pretty credible source. So the symptoms are listed here. Look, something I said here, an estimate 50% of shunts in the pediatric population fail. And these are symptoms that you can have when your shunt is failing. And I wasn't aware that they could be sort of subtle. The way that my friend described it, all of her symptoms hit her at once, and she was in an ambulance quite some time later, which is a little bit concerning. If you do have a shunt in place and you experience these symptoms, please dial 000, 911, 999, whatever your emergency number is. Another thing is that I didn't come across exactly how shunts could fail, and this website documents a lot of different causes. So very importantly, they have symptoms for different age groups, which is especially important in infants and toddlers because they can't necessarily tell you what's happening, and causes. So not only can it block, you can get infections and other mechanical failures, quite a few different ones, and in some complications, the valve can work too well and remove too much CSF. So yeah, once again, the website is saying what I've already said. If you experience any of these symptoms, Even the very subtle ones like the difficulty, concentration, and the irritability, you think you could be having a bad day, but it could be your shunt playing up and you're at risk of death. Please look after yourself and follow doctor's orders and my orders. I'm telling you to look after yourself. When I was a kid, one of my favourite shows was Father Ted. There's an episode where the classic drunken Irish fool, Father Jack Hackett, developed a condition called hairy hand syndrome. The show is definitely a product of its time, and I'm not very fond of the director, but it is a good show. Did the showrunners realise they were parodying a real health condition? Hypertrichosis is the excess growth of hair, not to be confused with other conditions associated with excessive hair growth, such as Hirsutism. Hirsutism is predominantly a biological female condition associated with androgen-dependent hair growth patterns, and is also seen in conditions like PCOS. Conversely, hypertrichosis isn't related to hormones, and the hair growth can occur anywhere on the body. Now, the hair growth itself isn't considered detrimental to one's health, but absolutely intrapersonally. This is reflected by low self-esteem and social isolation. But it could signal an underlying condition that affects the body, and of course needs to be investigated. Before we go on, we need to talk about different types of hair, because some forms of hair are present in some cases, but not all of them. There's languor hair, vellus hair, and terminal hair. Languor hair covers a fetus in utero and is shed shortly after birth. Vellus hair is the peach fuzz that we get in areas that don't have terminal hair. So for example, my face. And of course the terminal hair, which grows in our heads and well, let's just say the drapes are made with the same fabric as the carpet. Different types of trichosis can be distinguished from one another by looking at onset, distribution, and hair type. Depending on the source, different mechanisms of hair growth are at play. Congenital hypertrichosis lanuginosa includes conditions such as CDLS, Seckle syndrome, and Rubinstein-Taybi syndrome. These are mostly inherited in an autosomal dominant fashion. So mum or dad might have the gene, you have 50% chance of getting it. It's thought that this occurs because the fetal languor hair sort of stays put instead of being shed. The pairing of CHL and other physical abnormalities form what's called a malformation syndrome. Such abnormalities that can be seen are distinctive craniofacial differences, intellectual disability, and deformed organs and limbs. However, not all forms of hypertrichosis are malformation syndromes. In some cases, there might just be localized patches of excessive hair growth. These are commonly seen on the elbow, tip of the nose, or the lower back, with no other signs of abnormality. Acquired hypertrichosis usually presents with terminal hair growth on various parts of the body. Medications such as corticosteroids, tacrolimus, and minoxidil. That's actually a hair growth drug. So I guess it's working, just not in the place you want it to. It can also develop as a symptom of endocrine diseases. In other words, if it comes up out of nowhere, it's best to get it investigated. Diagnosis of hypertrichosis requires a thorough investigation into the patient's family history, their own medical history, onset, duration, hair type, and the locations and distribution of the hair growth. It may also include the use of trichoscopy as well as a follicular punch biopsy to examine the hair follicle itself and identify the hair type. If CH is suspected, molecular genetic testing of specific genes is conducted. CHL that we discussed earlier is actually caused by a section of chromosome 8 pulling itself up, turning itself upside down, and putting itself back in the chromosome. So how do you treat it? Well, how do you remove hair? Shaving and waxing are fine temporary measures for the average person. However, someone with hypertrichosis might need to repeat this weekly or daily, leading to skin breakage and skin irritation. Depilatory creams dissolve the shaft, but as well as the risk of skin irritation, they also might have an allergic reaction to it. In a 2021 study, Berdadesca et al. Identified that 4% capryloyal glycine cream was shown to reduce total hair density and length over a 4-month period. Only one participant experienced localized stinging, which is pretty good. Only one participant. Bicalutamide, a cancer treatment, was shown to cockblock testosterone and other androgens from stimulating hair follicles. This came from a 2022 study by Musa et al. Looking at minoxidil-related hypertrichosis in biological women that were experiencing head hair loss. So they got the hair, just not where they wanted it. They concluded that not only did bicalutamide reduce the hypertrichosis caused by minoxidil, but allowed these women to increase their dose in the hopes that it targets the head hair without any further problems. See what I did there? For permanent solutions, there's laser hair removal or IPL. It essentially works by either frying the hair follicle or forcing the body to convert the follicle into connective tissue. Because it selectively targets melanin, standard lasers prove most effective on very dark hair on light-skinned people. Other laser systems might be more effective in targeting people outside that demographic. You can buy these online or at the shops with just a lower level laser at the cost of efficacy. So you get what you pay for, really. Elephantiasis is a chronic and absolutely debilitating condition affecting 120 million people worldwide. It's endemic in sub-Saharan Africa, some parts of Asia, and some parts of the Americas. A 2023 paper I read said that 40 million people have been permanently disfigured by elephantiasis. Thankfully, the global program to eliminate lymphatic filariasis initiative has helped decrease the number of at-risk people from 1.3 billion in 2005 to 180 million in 2021, as reported in 2025. It is taking every fibre of my being to not assume they just killed off a bunch of people. Elephantiasis is a form of lymphatic filariasis caused by the threadworm Progeria bancrofti, delivered express to you by the humble mosquito. Fucking mozzies, when are we gonna wipe them out? Like, honestly, they have no purpose. They live to destroy. Just get rid of them. We've talked before about mosquito-borne diseases. You may remember the filariasis section in part 1. If you haven't seen it, go watch it. And then you can come back here. And then after that, maybe watch another one. Maybe another one. Even just a short. Come on, please. Let's first review the life cycle of the bancrofti worm. The mosquito holds the hidden passenger in its proboscis, ready to lunge into another host. Once the mozzie bites a human, the worm wastes no time getting into the lymphatic system. Don't worry, I'll explain what that is in due time. They mature in the lymphatic vessels and shed off baby worms, which are called microfilariae. Some of the microfilariae migrate into the bloodstream. Fun fact! Turns out the microfilariae are nocturnal. You are more likely to see them in the bloodstream at nighttime as opposed to in the daytime. Anyway, the next mozzie, if it's not already infested, takes a blood meal and sucks up the microfilariae. They mature slowly in the gut of the mozzie, and then the larvae migrate up to the proboscis, and the cycle begins anew. The lymphatic system is similar to the cardiovascular system in that they both have vessels and carry fluid around the body. Differences: the organs associated with the lymphatic system include the spleen, lymph nodes, tonsils, and thymus. Some of these organs are important in the maturation of white blood cells and in the destruction of abnormal cells. The 400 to 800 lymph nodes we have are dispersed all over the body, including our armpits, chest, abdomen, and groin. Basically what they do is they hold up a stop sign at any fluid wanting to pass through. You can see how they kind of look like kidneys, which also filter water and waste products to form urine. That water is taken out and returned to the body, same as lymph fluid. It also checks for any foreign particles or abnormal cells. Unfortunately, the bancrofti worms are able to sneak around undetected in the lymphatic system, and this also occurs in the bloodstream as well. So the lymph nodes aren't picking them up, and neither are the circulating white cells. And now that we've seen the adult worms make their way downtown, swimming fast, sneaking past, and they stretch you. Typically, in biological women, these vessel stretchings occur in the lower extremities, while biological men tend to get them in the vessels near the spermatic cord and the testes. And I want you to imagine this. You know those big bouncy balls that you sit on and they have the handles? That's exactly what it looks like. Billy Big Bollocks. The dilation of the vessel walls makes the flow screech to a stop. The one-way only gates that prevent backflow are now too wide to do such a thing. So you know how you go to the shops, right? Little grocery or whatever, and you walk through the gates. You can go one way, but you can't come back out. That's basically what I'm talking about. Back to the comparison with blood vessels. If our blood vessels got too wide, and their backflow gates stopped working. Consequently, blood flow wouldn't happen. Our tissues wouldn't get the oxygen it needs, and it would accumulate with all the crap that we need to push back out into the bloodstream, which is a huge problem. In this case, the trapped lymph fluid accumulates near the tissues, and that's what causes the swelling of the legs, the arms, that sort of thing. When the lymph vessels become too swollen, it triggers the body's inflammatory response, and in turn you develop what's called lymphedema. And this huge ballooning usually occurs in the legs and genitals. Recurrent episodes of lymphedema can cause tissue hardening, thereby progressing to elephantiasis. Right, now that we've gone through all of that, we can make way for the medical stuff now. Diagnosis is usually made by taking a blood sample at nighttime because remember, the microfilariae are more likely to be in the bloodstream at night, and they're looking for a characteristic particle called an antigen. So an antigen is a foreign particle that can be found on the cell surface of bacteria, parts of viruses, parasites. This is what triggers the immune system to go, oi, you're not one of us. We're going to attack you. There's also DNA techniques that can be used to detect Bancrofti DNA in the blood. Recently, another technique was developed called the lateral flow assay. The benefit of this is that it can be done any time of the day or night, because it's sensitive enough to pick up the levels of Bancrofti in the blood even during the day. In terms of treatment, the drugs of choice are diethylcarbamazine combined with albendazole. So these are both dewormers. The former is specific for Bancrofti itself. There's another dewormer that can be used, one that we're all very intimately familiar with, and that's ivermectin. So ivermectin can also be added to create a triple threat attack against the Bancrofti worm. Surgery may also be needed to relieve the pressure of the built-up fluid in the tissue. Finally, treatments of any secondary conditions that inevitably arise with elephantiasis, such as bacterial infections and other skin abnormalities. So by treating these, you're sort of preserving the tissue that's left. Toxic megacolon is extremely rare, but also extremely life-threatening. In this condition, the transverse colon swells to such a size that it takes up most of the abdominal cavity. So much so that it's not only picked up in X-ray, your abdomen is physically bulging from the mass. Let's talk anatomy first. The transverse colon is the middle section of the large intestine, connecting the ascending colon with small intestine to the descending colon with the rectum and anus. The large intestine's main jobs are to suck out as much water as possible to clump the poo together, otherwise it comes out as diarrhea, and deliver said poo to the rectum, the waiting room to see Dr. Porcelain. The main two causes of toxic megacolon are inflammatory conditions such as Crohn's and ulcerative colitis, and microbial infections by different bacteria and viruses, most commonly Clostridium difficile, a member of our gut microbiome. Diagnosing toxic megacolon requires a combination of physical examination, laboratory investigations, and CT scans, observing the diameter of the transverse colon. When observing a patient, their blood pressure, heart rate, and temperature are recorded. Blood examination often shows high white blood cells, anemia, and low electrolytes that can lead to dehydration. The average healthy transverse colon is about 5.8 centimeters in diameter, or 2.28 inches for you heathens using the imperial system. If the transverse colon is larger than 6 centimeters in diameter, it's considered a megacolon. But as you can see from some of these images, they look a lot bigger than 6 centimeters. Finally, doctors may or may not organize an endoscopy. An endoscopy is where they cut a small hole into the abdomen and shove a camera in there to see what's happening. This way, they can definitively identify the cause and see how much damage has been done. To treat the symptoms, they rehydrate the patient using an intravenous electrolyte solution. So, in any scenario, the the quickest and easiest way to deliver a drug or a solution of any sort is to go intravenous, because it's straight in the bloodstream. And they're also given steroid tablets to control the inflammation. Now, if the patient isn't pooing a normal amount of times per day, or there's still signs of inflammation, and especially if there's any bleeding, doctors will perform what's called a subtotal abdominal colectomy with an ileostomy. An SAC removes most of the colon, leaving behind the descending colon, and the ileostomy adds what only can be described as a secondary butthole. They remove about 2/3 of the large intestine and create an opening to connect to the small intestine, eliminating the use of one's God-given butthole. I can't imagine how difficult it would be to live with a stoma. Constant dehydration, liquid poo, oh my god, the smell, and if there's any leaks. I honestly really feel for people that have it. And I know I made jokes, but they're a lot stronger than I am. Finally, we have reached the final section of part 2 of the iceberg. And holy hell, what a way to end it. What the fuck? Now, when I say don't Google this, I really mean it this time. I made jokes in the last video saying, I'm not your parent, do what you want, I dare you to, lol. No, this is... Oh. Okay, so I did 7 years of medical science. I did 2 years of forensics before I started medical science. And this is some of the most horrific stuff that I've ever seen. You know, I'm very well acquainted with gore. It takes a lot to shock me. So yeah, Don't Google. I couldn't even find any safe for work visuals for this section. Myiasis is an umbrella term for when maggots penetrate the soft flesh of mammals, including us. And there's a variety of different flies that cause this. Now, because there's different genera, there's too many individual kind of species to look at, so I'm not going to do a life cycle for them. Though one of them you might remember is the Gasterophiliasis, which we looked at earlier in the video in relation to horses. If you do remember, that means you've been here a while. So please, like and subscribe. I think I've earned it. Anyway, all you need to know is that different flies infest different areas of different mammals. Let's talk about humans. Ostrus ovis affects the eye. Hypodermis species infects the eye, the groin, muscles, and even lymph nodes. Cochleomya hominivirax doesn't have a specific area that it likes, but the areas they do infest that cause the highest fatality rate are noses and ears. And the risk factors associated with developing this terrifying condition is exposure of open wounds, poor hygiene, and being in areas with high populations of not just the flies, but of livestock. The first point of diagnosis is identifying the maggot, and this is left to an entomologist, an expert who studies bugs. Now, you might have heard of entomologists being consulted in forensic cases. So when bodies are decomposing and there's maggots, entomologists can identify how old the maggots are and guesstimate an approximate time of death, which is really amazing. If I had the patience, I'd love to do entomology in a forensic capacity. But forensics gets you nowhere in Australia. I'm still better. Treatment of the infestation depends on where it is and what kind of wound it makes. I'm going to be following an outline of a 2012 paper that I found that really laid it out quite nicely by Francesconi and Lupi. And I'm going to restrict myself to surface level because I got a little bit lost in the source writing about all the types of myiasis and yeah, had to delete 5 pages. It's really interesting. If you can stomach it, it's really interesting to read. Anyway, let's get started. Cutaneous or skin myiasis has several forms at which it can present. Furuncular myiasis is when the maggot penetrates the skin and a large red lump forms, filled to the brim with maggots. Symptoms include itchiness, pus seeping from the wound, and the feeling of maggots underneath the skin. Of course, having an open wound leaves it open to opportunistic bacterial infections. So bacteria that can slide into the wound, get that yummy, yummy, nutritious blood and cause an infection. It can be treated in a few different ways. They can use chemicals to kill the maggots, suffocating the maggots and forcing them out of the wound. Jesus Christ, that would take me the fuck out. Or surgically removing them. Migratory myiasis is when the maggot decides to go walkabout and burrows through the skin. And they can move. They can move as far as 30 centimeters in 24 hours. That doesn't sound like much. This is a 30 centimeter ruler. A tiny maggot that would probably only be maybe at most 5 millimeters, maybe 4 or 3, traveling this long inside your body. Kind of cooked. Depending on the species that is causing it, they're either removed by using a needle or making a cruciform incision on the wound and forcing the maggot out. Wound myiasis is when the fly already has access to an open wound. Usually the wound is extensive and necrotic. Now we don't see necrotic wounds happen overnight. This is a lengthy process. This is where things like low income, lack of access to healthcare, and poor hygiene come into play. And unfortunately, these kinds of wounds happen in the most vulnerable populations, such as old people, people with substance abuse issues, and the disabled. Now, I could go into a massive rant, but I won't. All I'm going to say is that you do not see it very often in Australia. There's about 400 cases per year in this entire country of, 22 million? Thank God for universal healthcare. So treatment of wound myiasis includes obviously removing all the maggots, debriding the wound, so taking away all the necrotic tissue, disinfecting it frequently, and application of a low-dose ivermectin solution. Ivermectin comes up a lot. If you are wondering about the internal forms of myiasis, basically no organ is safe, which kind of makes sense, and each have their own treatment methods. I really wish I could go into it, but I won't. This video is long enough. Well, that was fun. The filming for this wasn't, but that was fun. Some of these are still quite common, but they are definitely more bizarre. And I'm looking forward to seeing some more conditions that I haven't heard of, and hopefully ones that scare the hell out of me. If you enjoyed the video, please hit like and subscribe to see some more medical content, as well as keep up with the uploads for the Strangest Medical Conditions Iceberg. Until then, you can keep up with me on Instagram or Threads at at darkly.dreaming.mistress. So you can see what other kinds of bullshit I get up to. You know, like adulting, studying, going to the gym, cleaning. Alrighty, I'll catch you next time. Bye, friends!